Hello, everyone, and welcome. My name is Elizabeth Benson, and I'm the president of the Alabama chapter of the Voice Foundation. It's my pleasure to welcome you to our August chapter meeting. Our leadership is up here on the slide. We are all in attendance today, almost, and all of these folks have contributed in some way to the formation of this meeting and the content of our ongoing activities. So I want to say a great thank you. Today, we are looking at the fascinating and ever-evolving topic of gender-affirming voice care in the studio and in the clinic. So we're really thrilled today to welcome guest speakers Ariel Zetina and Liz Jackson Hearns of the Voice Lab Inc., based out of Chicago, and Desi Gutierrez, based out of UAB for the moment. So we have folks here to talk about the studio side and the clinical side. So this is hopefully the first of several presentations where we would like to bring in both perspectives. So we're really reaching our intended audience here in the Voice Foundation, which is the intersection of clinical care and voice studio care. So we are really excited about this presentation. Ariel is joining us via a video, and Liz will be running that. But then we have Liz and Desi here presenting live. For any folks who are not able to join us here in real time, we will be following up with options for you to access the information and material. So just keep an eye out on our social media for any of that. So I'm going to stop sharing at this point, and very enthusiastically, I'd like us to give a welcome to our guest speakers, Desi and Liz, which is like, yay. Okay, yay, awesome. I love the applause. Wonderful. So Liz is going to start us off.
Hello. Thank you so much, Elizabeth. Thank you for having us. Thrilled to be here and be sharing with our community this way. Ariel is actually on a gig right now. And so she is in the woods hosting a dance party, basically. So she is joining us via video. She recorded generously, actually, a quite long video talking through some of her experiences as a transgender woman and a voice student. And so she brings that perspective among many others. She's also a musician. She's an international electronic musician and a DJ. She's a playwright. She does all kinds of things. So she's joining us via a short video clip today, but we're going to see if we can share the whole video with you. My name is Liz Jackson Hearns. My pronouns are she, her, and they, them. I am the co-founder and owner of the Voice Lab Inc. in Chicago and virtually all over the world. I'm the co-author of the Singing Teacher's Guide to Transgender Voices and author of One Weird Trick, a user's guide to transgender voice. I am joining you today to share some perspectives on support in the voice lesson studio. So we're going to talk through a little bit of terminology. Ariel's going to share a little bit about her voice experience, and then I'll give you some tools and language for navigating conversations with your students. And then Desi is going to follow up with some amazing practical application kinds of things and how to support students in a clinical setting as well. So
I'm so sorry, Liz. I forgot to do the rest of my job. I apologize for interrupting, but I just wanted to invite folks, if you have questions as you go, to please drop them into the chat, and I'll be monitoring them. If there's anything really timely that warrants an interjection, then we'll take that. Otherwise, we're going to hold questions until the end. And then when Liz finishes, then I'll give an introduction for Desi as well before we transition over. So thank you. Over to you, Liz.
So let's start this conversation by taking a moment to define gender. So what even is it? If this is the center point of our conversation, what are we talking about? So gender is a collection of constructs around the social idea of gender. Infants are most often assigned a sex at birth based on primary and secondary sex characteristics. Gender exists as a social construct, actually completely separate. So oftentimes we conflate the two of those things because that's the societal norm around gender, but gender can include all kinds of things. characteristics can include, obviously it includes voice, it can include mannerisms, hair, makeup, clothing, language choices, all kinds of things kind of lump into these constructs of gender. And part of our work is to become reflective on our interaction with, involvement in, perpetuation of, whether intentionally or not, the constructs of gender. So when we're talking about gender, I think as we enter into this conversation, it can be helpful to just define a few basic terms. So when we're talking about how gender is experienced, these two terms, cisgender and transgender, come up. So cisgender is an adjective to describe someone whose experienced gender is the same as the sex and or gender they were assigned at birth. So if someone was assigned female at birth by someone in the medical industrial complex based on primary and secondary sex characteristics, and they experience themselves as a female, feminine, woman person, that person is cisgender. Transgender is an adjective to describe someone whose experienced gender is not the same as the sex and or gender they were assigned at birth. So someone who's assigned female at birth and does not experience themselves as a binary female person could use the term transgender to describe their experience. These terms are hopefully coming from each individual person's description of their own experience. And as we talk about how we use these terms, I think it's really best to let the person define themselves and how they want to use language to describe their experience. In terms of binary and non-binary, so our historical social constructs of gender are pretty binary, male or masculine and female or feminine. A non-binary person probably experiences their gender or expresses their gender in a way that is not exclusively male or female. Could be both, could be neither, could be fluid. Gender fluidity describes someone who experiences gender on a fluid basis. They may feel more masculine, more feminine, more male, more female during different periods of time. The sort of defining characteristic of fluidity is that it is fluid, that it is changing. So some transgender people experience their gender in a binary way. Some trans people experience it in a non-binary way. Some non-binary people describe themselves as transgender. Some people don't. So as we're getting into this conversation, the key takeaway, I think, is to create an environment where each individual has the agency and the language to describe their own personal experience and how they want to relate to their voice in terms of their gender, and following along with the student however they want to be supported. One of the phrases that I always come back to is inform and affirm. So if a trans student is coming to you with a question about something, here is what I know, here is what's in the research, here is what I have experienced. How do you want to use this information and how can I support you as you do that? Never ever prescriptive, always descriptive and with lots of questions so that it's a collaborative environment between you and the student. I feel like I'm probably preaching to the choir with that, which is good. So glad we're on the same page. So the last kind of big term to talk about in this context is the idea of dysphoria. So dysphoria is the feeling of anxiety or discomfort, or that something is off or wrong about the person's experience as it relates to these societal constructs. So gender dysphoria is feeling off, feeling discomfort, feeling anxious about personal gender identity, expression, or perception as it relates to the social constructs of gender. On the flip side of dysphoria is euphoria, feeling really good. Ariel talks about these terms as like discomfort and comfort. So if I'm feeling gender discomfort about something, then maybe I want to do something about that so that I feel more gender comfort, right? It doesn't have to be necessarily like these life or death situations, although in some cases it is life or death. But seeking gender comfort is valid and everyone deserves that, of course. So as we talk about why someone might seek out voice care to alleviate some of that discomfort around gender and voice and find more comfort in their gender and voice. We talk about gender in 3 pillars, and the way voice kind of interacts with these 3 pillars is also part of our work. When we're talking about gender, I think all people experience gender along these 3 lines. The first is identity, is who I know myself to be. What is my gender? How do I experience gender? How do I interact with gender? And then expression is how I show that on the outside. Expression includes voice, of course, can include things like hair, makeup, shapewear, other aspects of transition that allow for or encourage more movement from gender discomfort to gender comfort by changing something on the outside. Gender perception is how the rest of the world interacts with me and reacts to me based on my expression of my identity and their preconceived notions of what gender is, looks like, sounds like, behaves like, what language gender should experience or be expressed with. So gender perception is the major element of the gender experience that we have no control over. We can influence gender perception in the way that we express our identity, but ultimately perception is the onus of perception is on the other person. So in this conversation about gender affirming voice care, gender affirmation looks different for each individual person. And the onus of perceiving someone correctly and treating them with basic decency falls to us as practitioners. And so we're here in this conversation to make sure that we have the tools and language to start to do that. So those are kind of some basic frameworks around gender. I'm going to share this clip with you of Ariel, and she talks about intersectionality. And intersectionality is the reality that we can't talk about gender without also talking about things like race, things like age, things like even religious affiliation, that all of those different pieces of the human experience can impact our experience of gender as well. It can also create hierarchical structures that are different between different teachers and different students. So this is something that we need to consider. And then Ariel's also going to talk about how she experiences voice along these three pillars. Voice for me as part of that voice identity piece, voice for the world in terms of that gender perception piece, and then voice for my art in terms of the way she expresses gender with her voice. So I'm going to mute myself and we'll watch this really cool video.
So this is a great tool that is used in order to map out intersectionality. Gender exists along other elements of identity and social constructs like race, ability, disability, language, geography, even religious authority. So we see here, this is a way to map out intersections of identity. We see, sex, race, ethnic group, language, religion, family, even stuff like clergy, geographic region you are now versus the one you were originally in. All of these affect how, we're perceived in the world and also how our gender is perceived. So this is a great tool used to map out this type of thing. You'll also get a great handout if you'd like to do this exercise yourself that has it in here. The idea is that we'd be putting the petals, I'd be putting like sex, race, ethnic group, where I feel privileged versus unprivileged, privilege going closer and unprivileged going out, so I can really see the map of how these things affect each other. Like, for example, I like this one because it doesn't have it written in. I always like to talk about, religion. That is a privilege or unprivileged based on geographic region, for example. Like that looks differently culturally, that looks differently across the map, across time. So that's just a good way to map this. I encourage everyone to look at this and consider that gender is only one petal on a bigger flower of everything. I think this becomes especially true because there is this implied hierarchy between teacher and students. I think one of the goals of the Voice Lab is to question that hierarchy and look at how these classic examples of who has power and who doesn't, how we are able to interrupt this in a lesson and look at a lesson more as a collaboration rather than as like this is the teacher and I do this. This is really student-centered teaching where the student is guiding the lesson somewhat or based on however much they want to be guiding the lesson. I know that I really work with my voice teacher in order to determine what I should do and what my goals are. But since, they're a vocal expert, I definitely listen to them and, take that into account because I'm not a vocal expert. I'm an expert on my own gender, on my own, on this world that my personal body lives in, which is very important to voice. But yes, I really enjoy working with a vocal expert as my voice teacher. Great. And I'm going to be like OBS. Sorry, I keep saying OBS. OBS is the program that I'm using to record this. It acts like it's a little more fancy than it is. So, this is, Liz will talk more about voice care and what it specifically looks like. But so why would we seek voice care? This is to alleviate dysphoria around voice and gender identity, expression, and perception. So the way I always talk about it is that, let's actually go in these three categories, and I'll talk about my experience in all of these. So voice for me, self-expression, exploration of identity. When I'm sitting alone and hearing myself, I initially didn't come to lessons and being like, oh, I have a ton of vocal dysphoria. It's always been like, this is my voice and this is what a woman sounds like. And if you have a problem with that, then that's your problem. I think I've maybe changed a little bit of how I feel about it once I've learned more about my voice. I think that from voice for me, my journey has been just like going to vocal health and going to making efficiency over work in my voice and doing that rather than necessarily so intensely tied to gender. And I don't know, my relationship with my voice is better because of that. But I know this is different for every trans person. I think there's a lot of trans women that are definitely, feel dysphoric when they hear their own voice. And that's a lot of the reason we're coming to this work. So, it always changes. Voice for the world is safety in public and with family and friends and job security. So this is actually the reason that I came to lessons. I originally came because I felt that I would get misgendered on the phone a lot. It's when you can't see the whole picture of me. People would sir me a bunch and people would just I would have these moments and I wasn't able to, do a lot of stuff on the phone, very important stuff talking to all of the many different press one, press two, all of these situations. I wasn't able to focus on what I needed to do. I was focusing on my voice, and I'm able to, focus on myself now and not have to worry about getting misgendered. I also think about getting in Ubers because it's a lot of the times I'm, sitting in the back, someone's not looking at me. A lot of the reason I started to was to be able to just feel safer in Ubers. It's definitely, I was just in a car in Houston, Texas, and it was just a very specific interaction. I was like, I'm very glad for these lessons for this way. So, someone isn't totally questioning me when I get in the car. I've had, experiences everywhere with this. It's not just I'm not just oh, in Texas, this happens in Chicago, this happens in New York, this happens overseas, et cetera, et cetera, et cetera. And then voice for art. So I tend to, explore more of my voice when I'm making music than I do, when I'm just day to day, because the voice is one of the instruments I use when I do electronic productions. So I really also, singing is a big part of my training at the Voice Lab, and also just being able to use my voice efficiently. There's so many times I'm in the DJ booth, I have to be the microphone isn't working, I have to be talking over music, and people have to be able to hear me. And a lot of that is just being able to I really realized that my head voice, I didn't know how to project my head voice, and I really didn't know about my resonators and how to get into my cheeks. And I was like, wow, this is so crazy, because no one ever told me that I didn't I went to theater school, so I was always taught, how to go for my diaphragm and do that. But it's just I've realized that there's so much more. Just knowing the more of the science of it and knowing more of that has really helped me be able to totally grasp what I'm, how I'm supposed to be using my voice. I think, I'm preaching to the choir right now, where it's I think all people should be in voice lessons, just because so many people use their voices in ways that if they knew other ways to use their voices, they would be a lot better. I think about how much I had vocal fatigue before starting voice lessons, and now it's kind of non-existent. So, it's a learning process, and I think we're getting there. So before we move on, as you've heard from me and you've heard from Liz, gender is a construct. It's something that humans created. We're trying to dismantle it, but it's a construct that still exists. The political, legal, and social ideas of gender are in place today regardless of our personal views on gender. Looking at these voice practices from both a binary and non-binary perspective is important. Gender affirmation looks for different for each student. So this is a great thing. I always like to bring this up because it's we're about to be talking about really binary stuff about how does a girl's voice sound? How does a boy's voice sound? And this stuff is very us trying to decouple it from these ideas of what a feminine voice sounds like and what a masculine voice sounds like. But, you know, gender affirmation looks different for everyone. For example, I always think about how, you know, she, her, using binary pronouns is very affirmative to me. Using they, them is something, you know, I accept, but it's not necessarily affirming to me because I really identify as she, her, and not.
Yay, thanks Ariel for your perspective. So anyway, so Ariel, the video is long. She's so generous with all of her stories all the time, and she just does such a good job, I think, relating these concepts to her lived experience as a trans woman in the world. So let's talk a little bit about how this shows up in the studio. And I want to give you some language examples and things that might come up in here we go, conversation in the studio. Oh, I did want to check the chat really quick though. Doot, doot, doot. Awesome, thank you. Great. There we go. Is that showing up okay? Looks good. All right. Great. Okay. So as we are jumping into starting this work, some questions that we might try to put into intake forms or new student forms might be well-intentioned, and let's be really specific about the language that we're using. So this first question, what is your real name and what are your preferred pronouns? The intent behind that, I think, is to be supportive and inclusive. Instead, a good practice is to start by naming yourself and your own pronouns and how you would like to be addressed in the space that you share together. And then asking in return, how can I address you and what pronouns do you use or what are your pronouns? And then letting the students know how to do that from an administrative perspective if they need to update anything, if they need to update their name and pronouns at any point, letting them know this is how you can do that if they haven't already been guided through that process, which they may not have. And then giving context, if you need to know the legal name of any of your students, giving context for why you would need to know that and how it's used is really important. That helps them to kind of feel like they're at least able to give some consent around how that information is utilized. Similarly, with this question, are you out? And making any kinds of assumptions about someone's identity based on your experience with them. Again, I think the intention is to try to keep the student safe. So rather than kind of going around it or asking an invasive questions like that, let's set up some kind of boundaries for communication. And this is something you can do with all of your students. All of these practices are great for all of your students. What kind of boundaries would you like to set together? In an email, what name would you like me to use? Or what email address should I be sending things to? If I have to call you on the phone, if I need to leave you a voicemail, how would you like me to address you in the voicemail, or should I address you at all? One of the standard practices of the Voice Lab is when we need to leave a message for a student, we don't use their name. We just say like, this is Liz from the Voice Lab, just calling to see if you're on your way for your appointment. And that's it. If you see the student in the hallway, how would you like them to be, or how would they like to be addressed? Same thing with parents, colleagues, classmates, other teachers, or even on the street. So you may be working with someone who's not out in any other part of their life yet. I have had students who, when we talk through this part of it, have requested that we don't know each other on the street just because our studio was close to their place of employment. And so if anything had gotten back to their employer, their job would have been at risk at that time. So setting up these boundaries for students can be really helpful and can, again, give them some agency in terms of how they are supported in your teaching relationship. Then this question, do you want to feminize or masculinize your voice, is kind of inherently binary. So rather than implying any kind of binary, like, let's actually talk about this. Like, what are we really talking about? What do we really mean? What is your ideal experience of your voice? What do you want your voice to do or not do? You can talk through things like range, colors, characters, genres, and styles. And I think specifically in terms of in the singing voice, when we think about voice types, repertoire, roles, oftentimes that conversation is loaded with gender expectations. So rather than making any kind of presumption about what the student wants to do with their range or what kind of characters they want to play, who resonates with you? What kind of characters feel reflective of your experience and how, so that you can take that information and then give them alternative recommendations, or like help them go down the research rabbit hole for themselves in a way that's affirming and never presumptive or prescriptive. And then this one, this sort of like inquiring about medical backgrounds. And this is kind of the same. We'll get the surgery question, I think, is next. So in terms of inquiring about this information, what I see sometimes from teachers is a feeling of that the student owes the teacher this information. And I disagree with that. I don't think that the students owe you any information at all. And I hope that you will take that into your conversations with your students. So instead of asking, are you on hormones? Because again, your student doesn't owe you that information. What really are the things you would do if they were or weren't, right? So you'd really be navigating around things like symptoms, right? So are you experiencing any symptoms? Are you having any excessive dryness or coughing? Do you have any weird tastes? You know, maybe there's some signs of reflux or something there. Are you having any unpredictability or unreliability in the voice? And when you open up the question, I think in this way that makes no assumptions, then the student can choose how much information they want to give to you. And then you get to use your really amazing ears as a singing teacher to evaluate what you're hearing and the function that you're hearing in the voice, and then navigate appropriately from there. You don't have to ask questions that coerce the student into giving you information, whether intentionally or not. And then same with shapewear, anything that might impede the way you take a breath. Like that's the open-ended question. And again, you can ask that of any student at any time. In this time of online lessons, maybe the student is wearing a tight belt or something, and that might be impeding their ability to take a deep breath while they're sitting down, anything like that. So we're opening that question up. Same thing here, surgery. Are you experiencing any symptoms? Are you having anything that might interact with our work together, rather than, you know, inviting or coercing that conversation around a medical history. So then great. So after we get through the intake form and we have these kind of ways of reframing the way we begin the conversation, so that we are even intentionally creating a space of consent and agency for the student to share whatever they want with us. The context that I want to give to that is that many, many trans folks throughout their lives are coerced into oversharing. If you've never seen the movie Disclosure, I recommend going to see Disclosure. It kind of highlights this idea that society feels often that it is owed the disclosure of trans identities by trans people. And so the opportunity for us is to not perpetuate that and to create an environment where no information is owed, disclosure of anything is never owed, and we don't want to coerce anyone to coming out or inviting us into their process without their consent and their ability to give agency about that. So along those lines of agency, another piece of language that I want to offer you is this phrase, what would it be like? So often in a voice studio setting, we are encouraging students to try something with their bodies that they may not have done before, or we're asking them to experience sensations that they've never had before. Especially if someone has a lot of dysphoria around the body, they may feel disconnected from the sensations of the body or disconnected from their experience of their body. So this phrase, what would it be like, allows them to make a decision about how they want to engage with a directive. So instead of saying, take a deep breath, instead of saying, look in the mirror, instead of saying, open your mouth, instead of saying, I want you to try blank. What you can do instead is, what would it be like to take a deep breath? What would it be like to sing that phrase again while you're thinking about XYZ directive? What would it be like if you opened your mouth a little bit more or closed your mouth a little bit more? What would it be like if you invited yourself to feel sensations in your face, rather than just telling the student what to do or telling them what you want them to do? Because ultimately it doesn't really matter what you want. It really matters what they want, right? So inviting them to to choose to engage in that activity by asking, what would it be like? Because in that moment, they can say, that would be really helpful, or like, that would be really awful. Then you have a choice, like, okay, great, that's awful. Here's what I'm going for. What other ways can you think of, or can we think of together to get to that effect or that result or that sort of, desired outcome that we have together? And then the third kind of bit of language and things to think about that I want to offer you as you go into this process. So we talked about how you start. We talked about consistency in terms of always giving agency to your students and always creating that collaborative environment that lets them choose how much they want to engage in the directive or the project that you're working on. And then lastly, I think as we come into this work, our hugest responsibility is to do the self-work that is required to show up for your students this way. So if you have not yet spent considerable time thinking about your gender, now is the time to do it. What is your gender? How do you know? How do you express your gender with your voice? What do you do with that? What's your pitch range like? What inflection patterns do you use? What kind of resonance patterns do you use? How do you use articulation? When you are trying to communicate different kinds of intent, how do you change your voice to do that? How do you associate each of those elements of voice with gender? And then do you feel aligned with your gender identity and the way you express your gender with your voice? And then how does the rest of the world interact with you based on their ideas of gender and how you express your gender with your voice? And does that feel aligned? And now is the time. So if you have an opportunity to journal about this as you start this work, I highly recommend, it's required work, really. I think in order to come to this conversation, we need to walk through that place of empathy. In this process of being teachers, we are lantern holders while our students walk through the woods of their own experience, but we have to be on the path too. We can't hold the lantern from outside the woods. We have to be in it with them, which requires us to do this self-reflective work as well. So thank you for letting me spew information at you. I hope this has been helpful. And I'm going to turn it over to Desi at this point to kind of take it to the clinical realm.
I'm going to interject momentarily. Thank you so much, Liz and Ariel, for that. I do have Ariel sent along a gender self-reflection worksheet, which is a really helpful tool to begin that conversation that Liz was just discussing. So I'm going to drop that in the chat here, but then we will also have it available when we make more of the materials available after the meeting. So at this point, I'm very happy to introduce Desi Gutierrez. It was certainly my intention to read everybody's bio out loud, but since I forgot to do that for Ariel and Liz in my excitement about getting started, I'm going to drop Desi's in the chat as well, and you can go ahead and scroll through and read there. So take it away, Desi.
Awesome. Thank you so much. And thank you also to Liz. I think that was a great presentation and a great way to kind of set up a lot of the stuff that I'll be talking about. So this is exploring gender affirmative voice care more from the clinical side. My name is Desi. I'm non-binary. I use they, them pronouns. I'm the current clinical fellow at the UAB Voice Center. So just a couple of disclaimers before I get started is I want you to ask questions. I want you to ask questions in the chat. We're going to have some time at the end to ask questions. As long as you keep it respectful and on topic, I am completely an open book. I speak from my professional, academic, and personal experiences. I do not speak for all trans or LGBTQ people. And gender affirming voice care is very nuanced. You're not going to get everything you possibly need to know from an hour and 15-minute presentation. So continue to do this work, continue to explore and seek out that information beyond today's talk. So this is kind of what I want to talk about. Some basics and key concepts, some considerations for the clinic, evaluation protocol, medical and behavioral intervention. And Liz did a fantastic job of going over a lot of the basics and the key concepts that I wanted to explore. But I kind of want to sit with this question for a second. How would sessions differ between a cisgender patient and a transgender patient? I mean, think you have somebody in front of you. How would things change if they were cisgender versus if they were transgender? I think the key difference with this question, or kind of the trick with this question, is that this question has nothing to do with gender affirming voice care. This question has nothing to do with somebody coming and sitting in front of you for gender affirming voice. Trans people get strokes and cancer and nodules and polyps and subglottic stenosis and MTD and Parkinson's and all these other things. So first of all, the sole fact that somebody is trans does not mean that they're in your office for this particular reason. Okay, but how does treatment change if a patient is presenting for gender affirming voice modification? I think to break this question down, we have to kind of sit with two different things. First, what is the purpose of gender affirming voice care? And Liz and Ariel did a fantastic job of kind of exploring this. I kind of conceptualize it as to increase congruence between an internal sense of gender and an external expression. And that can also be known as vocal euphoria, and from Ariel's talk, voice for me, voice for the world, voice for art. And with that in mind, is gender affirming voice care only for trans patients? No. I mean, think about the guy that comes in your office who he's got a vocal fold paralysis, so he has he's got paralytic falsetto, and his voice is really, really high, which is not congruent to his gender. He has gender dysphoria. He has vocal dysphoria. Or the woman postmenopausal, now her voice is naturally a little bit lower, and she is also coming to you for gender affirming voice care. So just some kind of ways to frame this conversation. So just basic vocabulary, we already discussed what transgender, cisgender, non-binary means. Some other vocabulary that I'll be using today and to kind of put in your arsenal are transmasculine and transfeminine. This is a pretty binary way to look at things, but it kind of notes the direction of transitioning without mentioning gender. I like saying this, especially with non-binary people, if we're talking about, well, transmasculine people, who would take testosterone? A transmasculine person, because that includes trans men and transmasculine non-binary people. To define transitioning for a moment, long story short, transition is a process. Transition doesn't happen once. You need to come out to lots of different people. You need to transition across several modalities of life, physical transition, social transition, and legal transition. So this is not like a one-stop shop transition and you're done. And this concept of passing. So this is a trans person is perceived as a cisgender, as cisgender. And this idea is kind of contentious because a lot of trans people do intend to pass. So a trans woman wants to, that assumption of femininity, that assumption of womanhood, but other people kind of feel like passing is kind of like constraining. So I have to do this because somebody is going to place gender on me, and I don't want people to place gender on me. I just want to exist. I have no need to pass. And the whole concept of transitioning is much larger than passing, because passing is just in a social context. And when trans people go home at night, they also want to present and have that congruence without the social element. So here are some considerations, sort of more clinical in nature. First of all, the legality of gender affirming voice care in Alabama. As of May 8th of 2022, there was a Senate bill that made it a felony to provide transition-related medical treatment to transgender and gender nonconforming minors, punishable by 10 years in prison. The next week, there was a temporary injunction to block felony charges for puberty blockers and hormones, because taking somebody off of puberty blockers and hormones cold turkey can be very dangerous. But they upheld the ban on gender affirming surgeries. These laws did not mention anything about behavioral interventions for minors, nor did they mention anything for transgender adults. However, in the wake of Roe v. Wade, I've seen it being overturned. I've seen some talk of different bills trying to illegalize gender affirming voice care for transgender adults. So keep your eyes out. So clinical considerations. Their chart might reflect their dead name or gender. So somebody's dead name is a name that they no longer use. Their legal name, So the name on their birth certificate, the name that's most likely to be on the EMR, could be their dead name, so the name that they first got when they were born, or it could be their new name, or the name that they are going by now, and the name that you should call them. So look for other indications in the chart of their name. And if something's not right, or you want to double check, ask them for their name and pronouns. A lot of people do open up with like, hi, my name is so-and-so, these are my pronouns. And if you feel comfortable doing that, by all means, I think that's a great way to allow people to be comfortable in sharing that information. Personally, I don't feel comfortable doing that. I feel like I don't feel safe always doing that, coming out to every patient. And I've also had the patient who went on the transphobic rant to me. So I try not to, I don't very intentionally introduce myself with my name or gender, or with my gender. I introduce myself with my name, but just something to consider moving forward. Every patient will have a different level of outness, or how open they are with the world. And for gender affirming voice care, kind of in the speaking voice, I do feel like it's important to kind of understand their level of outness, in part because it can help us understand where they are and where they are going. And it also helps us develop goals. So starting with the people that either they're already out to, or the people that they feel most comfortable with, those are the people that you can like start to practice. And then if you're creating like a fear hierarchy, kind of building it up from there, and treat all information about them and their experience with the level of respect it deserves. You might be the very first person ever that they are coming out to. So that's a lot of responsibility to hold. Transition is very personal and may be very sensitive. Create a strong sense of privacy. Don't ask irrelevant questions about their transition. And if you do have to ask a question that might seem irrelevant, justify it. For example, asking people about bottom surgery. At first glance, it's like, that's not relevant at all. But if this is a patient who's coming in and wanting surgery, if they have a Wendler's glottoplasty, if they are coming in for that surgery, in the future, they might be more difficult to intubate. So if we know that they have big surgeries coming up, we might want to delay the medical intervention until other surgeries are out of the way before we can kind of address vocal surgeries. Patients might be distressed by seeing or hearing themselves. So ask the patient what they're comfortable with, move mirrors, and minimize playing their voice. Whenever I record somebody's voice, I always ask them, is it all right if I play it back? Or if I'm testing their range, I want to see how high they go, how low they go. Are you okay with that? Are you comfortable with going all the way up, or are you comfortable with going all the way down? You're likely not the only person seeing them that day, so communicate any relevant information about their name or pronoun to nurses, MDs, the front desk staff, etc. If you can, get it updated on their chart ASAP. And trans people experience discrimination in healthcare, so it's important to be aware of the common microaggressions and how to avoid them, and appropriately apologize for mistakes. If you accidentally misgender someone and then go on a 2-minute, oh my gosh, I'm so sorry, I never do this, I'm so, like, it's putting the patient in a really kind of uncomfortable position. So here's a great study. I'm not going to go over it right now, but these are some very common microaggressions from Nadal et al. 2012 that trans people experience in healthcare, and this article in particular talks about implications for counseling. So check that out. So now talking about the voice evaluation. So kind of talking about somebody's transition history. Obviously you want to know their names, their pronouns, who they're out to, kind of their level of outness, like we already discussed. Medical, if they are on hormones, if they were on hormones, that changes kind of the direction that we go and possibilities of transitioning moving forward, and relevant surgeries. And voice specific, I think this one is really important. So asking about their plans, their goals, their expectations, their preferences, any previous voice interventions. So any previous therapy or surgeries or singing lessons or anything like that. And attempts to modify their voice independently. There's a lot of information online that's like, go here if you're trans and you want to change your voice. But a lot of people get like lots of excess tension from doing that. So it's kind of important to understand what they've already done. And again, to make a plan moving forward. Kind of a general history. So voice use, their occupation, singing history and singing training, medical health issues, surgeries to the head and neck, physical activities like yoga and meditation, and smoking and alcohol intake. And I think this one is really interesting with what Ariel was talking about with intersectionality, because more LGBT people than non-LGBT people are still smoking. And there are a couple of different explanations for this, like the minority stress model. So people who are minoritized face more stressors and unique stressors, which have negative impacts on their health. And I mean, tobacco marketing specifically to LGBTQ plus people. While putting research together for this presentation, I saw something that was like, smoke your pride or pick your color. And it was like packs of cigarettes in like different colors. Yeah, so smoking or tobacco companies are always gonna aim at whoever's gonna buy, vulnerable populations. So now talking about PROMs, patient-reported outcome measures, there are specific ones for transgender women, transgender men, and non-binary people. And the most common vocal PROM, the vocal handicap inventory, there's mixed evidence regarding if it actually applies to trans people seeking gender-affirming voice modification, where there's some evidence that say these measures correlate with the VHI, and then there are some that say that they do not. So now the perceptual component of the evaluation, during conversational reading samples and prolonged vowels, having a good concept of their voice quality, pitch, loudness, locus of resonance, breathing patterns, speech and language, and nonverbal communication, all things that we can kind of address in therapy. Acoustic evaluation, it's really good to have a good understanding of their vocal abilities as they're coming in. So their average fundamental frequency, habitual pitch range, physiologic pitch range, their average vocal intensity range. And if they have begun to self-modify their own voice, it would be important to do these with and without those self-modifications. Again, if the patient is comfortable doing that. And then a laryngeal examination. There is a study that came out, Young et al. 2021, that found that in about 5% of their 61 participants in their study, they found abnormalities on their stroboscopy. And they took from that you should perform laryngeal examinations on every trans patient coming in for gender affirming voice. But I think it's hotly contested, because especially if somebody is coming in without any previous voice complaints, the utility of the laryngeal examination can come into question. So just a moment on medical management. So for people who are assigned male at birth, so the trans women and trans feminine non-binary people, some different hormones that they could take are estrogen and hormone blockers. If they're younger, also progesterone is on their surgical treatment. Kind of a Wendler's glottoplasty is the most common one these days. And this is where on the vocal folds, there's basically a scar. The vocal folds are made shorter by scarring up the bottom at the anterior commissure, which creates a higher pitch. And for people assigned female at birth, so these are the trans men and the transmasculine non-binary people, androgens, testosterone, hormone blockers, and there are also surgical treatments like vocal fold augmentation. The thicker the vocal fold, the deeper the pitch. And a note on testosterone in particular, it causes thickening of the vocal folds. And like I said, the thicker the fold, the lower the pitch. But with testosterone alone, Ziegler et al. 2018, they did a great meta-analysis that found that about 1/5 of patients did not fully enter male norms. And even people who did reach male norms, some of them were still not satisfied with their voice because testosterone in medical surgeries only change pitch. And there are lots of other things that convey gender in our speech and communication. And a lot of people complain with just being on testosterone that their singing voice is different, that my range is different, and I don't have the repertoire that I used to. So moral of the story, medical interventions primarily address pitch, and nothing is perfect, and every approach has trade-offs. That's not even to mention that testosterone has other global effects on the body. And if this is a person who just wants to lower their voice, they might not want to go on testosterone because they might not want all of the other impacts of testosterone. All right, now talking about behavioral intervention, just a second to talk about the Therapeutic Alliance and patient preference. This is data from my master's thesis, and we asked participants whether they preferred match factors, so whether they preferred a clinician who was their same gender or who was also LGBT versus somebody who had strong clinical abilities. So somebody with training and experience with trans people, strong knowledge of up-to-date issues in language, or people with really strong empathy and acceptance. And by far, number one, people were willing to sacrifice 70% of treatment efficacy, the maximum they could sacrifice, for a clinician who's empathetic and accepting. And they defined that as being flexible, being humble, and being curious, not coming in with a cookie cutter, not saying this is how you should transition, and really being open to talking with your patient and learning what they're about and what they want. And number two is the issues in language and asking them what they meant by this. They specified that it's important to know the sociocultural experiences of trans people, know what that person is dealing with, number one, before they walk in the door, and number two, after they leave. Like, understand what you're asking this person to go do. Go practice their voice with who? That person I might be very nervous to practice with that person or in that scenario. I might be in danger in that case. And then somebody with strong voice knowledge. So I think this really highlights the importance of that empathy and acceptance. People want a clinician that they can trust and a clinician that they feel safe with. So now we're going to take a couple of minutes to talk about the components of voice modification. And the most important thing to say here is that there's no one way to transition. It's not a cookie cutter, it's a charcuterie board. There are lots of different things that you can do, lots of directions you can go, and patients are going to come in, and the majority of gender affirming voice patients that I've had, I come in and I'm like, okay, what do you want? What are you looking for? They're like, I don't know. They just don't have the language for it yet. So kind of presenting these things to them as options of different ways that you can go. And I think something else that's important to acknowledge to patients, first off, obviously this is for a trans woman, but if you are a woman, you have a woman's voice. The rest is extra. If you're a man, if you're a trans man, you're a man. And if you're a man, you have a man's voice. There's no such thing as like an ideal woman's voice or an ideal man's voice that we're trying to like reach, because you're going to find cis women that don't fit into that standard. So this is all exploring, and this is all what this person is looking for. So talking about pitch. So the elements of pitch that impact the perception of gender, the mean fundamental frequency and the upper limit of fundamental frequency. And speaking fundamental frequency in this meta-analysis, Leung et al. 2018, they found that speaking fundamental frequency contributed to 41.6% of variance in perception of speaker gender. I mean, that's nearly half of what contributed to everything was pitch. And at the bottom here, I have some norms that they laid out for men, or to clarify, these are not male norms in, let me rephrase, these are not the norms of cis men and cis women. These are the perceived gender norms. So in reality, the male average might be very much lower than 155 hertz. But if you hear somebody on the street who's speaking at 155 hertz, you're more likely to perceive that person as male, which I feel like is more important than the honest to goodness gender norms or sex norms, because in this context, at least, this is that perception piece. So male 100 to 155 hertz, kind of an androgynous zone, 155 to 180, and female 180 to 300. But of course, this is age dependent, culturally dependent. Again, that intersectional piece that really comes into play with these. Resonance and articulation. Again, this is very gendered, but one great way to do this is exploring kind of on the vowel quadrilateral. So if anybody's not familiar with the vowel quadrilateral, imagine this is your tongue so that E is very up and front, U is kind of back and high, Ah is low and back, and Ah is front and low. So kind of exploring, playing between all of these and saying, well, what feels right to you? What feels better when it kind of comes out of your mouth? And using things like resonant voice, SOVTs, to find and establish those things. Kind of on the feminization side, kind of, again, what is perceived as more feminine are higher formats. So increased tongue height, fronted tongue position, reduced oral cavity length, so that E sound, a lot of trans women really like. And then that what is perceived as masculine are those lower formats, so decreased tongue height, back tongue position. So I really like to use or ah with my trans guys. And is that all you need? Because there's some evidence that says that really adjusting the formats, adjusting the pitch and the resonance with the other format frequencies, that pretty much captures all gender perception. It's all wrapped up. But there is mixed evidence on how just pitch and just resonance are correlated with the satisfaction of trans women and trans men, because it's more than just pitch and it's more than just resonance. So again, here are some other things to work with your clients, with your patients with, in order to achieve that quality of life that they're, and that voice that they're looking for. So intonation and prosody. With more feminine prosody, it's kind of read as rising, a larger semitone range, a higher pitch range per duration, increased upward and downward shift patterns. It's moving up and down more, and it's moving higher and lower than masculine norms, and a decreased degree of downward shift. So it's a lot of up and a little down. Long story short, larger and more frequent pitch variation. And you would not be surprised to know that the masculine norms are smaller and less frequent pitch variation. And I think an interesting piece here is that to kind of drive home the point that these are not sex norms, these are the perception of masculine and feminine norms. There's some evidence to suggest that men actually have wider pitch ranges than women do, even though wider pitch ranges are perceived as more feminine. Throw that on the pile of this has to be really patient dependent. Some other things that are perceived as more feminine, legato and smooth, more variations in the speech rate, and variable vowel duration. Variable vowel duration. Masculine, it's more short, more staccato, more disconnected. And speech rate itself does not impact the perception of gender. So kind of talking about intonation and how you might do this in the clinic. So that kind of upward pitch is a great place to start for some people. Setting goals like a range goal. So I want this to be 10 to 14 semitones at least. And an easy way to track that is with recording equipment. Other ways to kind of introduce intonation. This is fun, this is the Dracula intonation. For the patients who have a really difficult time breaking out of a more monotone pitch range. I want to drink your blood. Like high, low, high, low, high. Obviously, it's not particularly ecologically valid. You're not going to send anybody out of the clinic doing that. But it's a great way to break people out of a more monotone pattern. So try it at home. I need to be up there. to be or not to be. And I'll have fun with those. Another common one is walk, jump, step, fall. So this is a little more natural. Not all sentences fit, but this is a walk, jump, step, fall. So it's another way to make sure your whole range is there without it being like, so good examples here. The cat is fat. I love your hat. So try it at home, folks. All right, for masculinization, again, smaller, less frequent pitch variation. So your goal might be to decrease the number of semitones, easy to track with voice recording equipment, and practicing with short phrases, kind of monotone and drop. Larger drops, again, smaller drops are more feminine, larger drops are a little more masculine. So working kind of in that straight and down direction. Voice quality and loudness, kind of a feminine, is a lighter, more breathy, and oddly enough, tenseness is perceived as feminine. Of course, we're not teaching people to be tense, but kind of an interesting relationship there. An inverse relationship between breathiness and vocal intensity. So the louder you are, the less breathy you can be, but you can always work on maintaining that breathiness while increasing your vocal intensity, and increased variations in loudness. And masculine, more perceived, are increased loudness and decreased breathiness. So language, like everything else here, there's a strong interplay between gendered language norms and norms relating to culture, class, and age. This is a really interesting paper, Robert Lacknoff, and I think now it's kind of read as kind of like old, and it's not particularly good. But at the time, this was an incredibly feminist work, Language in the Woman's Place. This was a work that talked about how the marginality and powerlessness of women is reflected in how women speak and how women are expected to speak. So, for example, a large set of words to their interests, but not to other things, empty adjectives like divine, lovely, precious, asking questions for something that you actually know. What's your name? Mary Smith? I know your name is Mary Smith. I'm just going to say Mary Smith. Super politeness, asking more questions, not being all that direct. So kind of an interesting thing to keep in mind if your patient is interested in working on language. And nonverbals. Yes, it is in our scope of practice. Gender is very much read through nonverbals. These include body movements, touching behaviors, distance from other people, the use of your eyes, smells, physical appearance, the use of time, the use of your environment. Again, these are highly dependent on cultural norms. And these are just a couple of examples of nonverbals. So something that is perceived as more feminine, head movement and kind of leaning in while talking, kind of an S position, leaning toward their conversation partner, using more facial expressions. Whereas something that's more masculine would be more static position, kind of that A pose, linear gestures of the head and of the arms and the hands with fingers closed. And I don't think we've got time for that. So with all of that information, some helpful things to use in therapy, old trusty piano app to kind of set a patient's goal, their kind of fundamental frequency goal, and use that to kind of center them. Voice memos, record their voice if they're comfortable with it, and watch, like this is the Rainbow Passage week 4, but listen to how that changes over time. And listen to it last week. Oh, last week, I actually kind of liked it a bit better. Oh, this week, my range is a lot bigger. You know, give them the power to kind of analyze and work with their own voice. Voice tools, this is an app where you talk and it shows you follow the bouncing ball, and you can see where your frequency is. I've had some criticism recently from patients that from me as well, that it's like, all right, you better stay in the pink. All right, ooh, you're kind of getting in the blue. Like there's so much more to voice as we've been discussing than staying in the pink or stay away from the blue. And voice pitch analyzer kind of does the same thing. It shows kind of on the range from masculine to feminine. So you read a passage and then it shows you your lowest, your pitch range, and then your medium pitch. And then just to wrap us up, a comment on individual versus group therapy. There are a lot of benefits to a group model. So not just the one-on-one therapy with a speech pathologist, but also getting into a group. You can hear the speech pathologist's feedback with other people. You can practice in a comfortable setting. It's more cost effective. And it establishes a peer group for some people that might not have a trans or LGBT peer group. And the outcomes are pretty good, especially with the hybrid model. So a model where there are some sessions one-on-one with the SLP and then a group session to kind of apply things or to learn from others and expand it in that way. So here are my references. Thank you so much for your time. And I think we're gonna open it up to questions.
Thank you so much, Desi. That was chock full of really helpful information. I love that Dracula intonation. I'm going to use it with my students who have trouble matching pitch. So that's really great. Thank you. And thank you, Liz, for a really fantastic setup for us on the studio voice side of things. So at this point, yes, we have a few more minutes. We can open it up to questions from the group. I didn't see any come into the chat. So if you did type one into the chat, please just go ahead and unmute. We have a small group here, so we can just go ahead and informally unmute and voice your question. And if there aren't any, I have some, but I want to open it up to people first.
Elizabeth, I definitely have one. So I will, I'm going to direct this to Desi. Hey, Desi, my name's Brandon, pronouns he, him. I'm also in Alabama, so I feel the pain with that. Not your pain, but mine, of course. Trust me. But I am a studio owner in Daphne, so Low, Alabama. And we currently have 5 students who identify as trans, at least outwards towards our faculty. And I know one of my students who is AFAB has recently started testosterone. And for everybody else, AFAB, assigned female at birth. She was born they were born female, now identifies as male, uses they, them pronouns, has started testosterone. What should I guess, worry about with them as a singer on testosterone when it comes to the negative effects of testosterone?
Yeah, so I think a little bit about my background. I am not a singer. My piano is my bread and butter. So I want to defer that to Liz for her perspective, for their perspective. But at least the biggest thing that I hear and what I experienced was a loss of like an upper range. So everything kind of, my modal or my physiological pitch dropped a full octave. Like I went from my lowest note being E and my lowest note is now E again. So along with that comes with changes in repertoire, changes in, roles or different things that you are, your goals, I'm sure. So I think that's the biggest thing. And it takes about a year for people on T to have like their voice. So especially in that first year, they're probably going to have a lot of like voice cracking or like being kind of like, I've found like being a little embarrassed to even like use their voice because think about the motor patterns too. Like I know that if I open my mouth and go, ah, it's going to sound a certain way. But now if I open my mouth, it's going to go, ah. So you kind of need to like relearn how to sing things and relearn how to find that note, redo that kind of motor pattern. Otherwise, I would love Liz's perspective on this.
Yes, please.
Thank you, Desi. Yeah, this is such a great, relevant question. So there are some excellent research resources out there. Tessa Romano, Felix Graham, Alexandros Constantis is like the Bible of voice and T. Have all really wonderful articles that that definitely to check out. One of our staff members, Soren Ostenfeld, has also done some presentations and poster kind of work for that too. So some great resources are out there. The general gist of a body, the difference in hormonal transition for a body that produces its own testosterone versus bringing it in from an outside source, especially if that body has already been through an estrogen-based puberty. The major difference is that in a body that produces its own testosterone in adolescence, the structures of the larynx kind of follow suit. So in a body that produces its own testosterone, you would see changes in the size of the larynx, the skull, all of the structures in the body around the larynx that make an acoustically happy environment for lower pitches. However, in an adult person who is bringing in testosterone from an outside source, that structural change does not follow suit quite in the same way. And so the concept of like entrapped vocals kind of refers to the idea that the vocal folds are bigger, but the housing around them is not. And so they are literally entrapped. They're too big for their house. So that can lead to some different kinds of challenges around things like registration, literal amplitude of vibrations, which can result in like changes in volume control, any kind of like relationship with breath. Desi's talking about things like range changes, and those articles again are really great to kind of walk you through what to expect. In the first 3 months, for sure, like top end is gonna like disappear, and then we might see some bottom end coming in that the second 3 months up to 6 months. I lovingly call it garbage town. Usually like the most limited range and the most unpredictability in the voice. You know, we're open about it, right? Like, hey, how's garbage town this week? Cool. Great. Let's kind of work through that and see what we can do today. And then after 6 months, slowly things start to kind of stabilize again. By a year, like Desi said, I would expect much more stability. After 2 years, for sure, we're usually pretty solid. Things have changed about as much as they probably will. Many of my students who have gone through T, who are singers, have regained their higher end. And so then we get into like really phenomenal things that the human voice can do. And we get into like these really wide pitch ranges and ways of making color and navigating registration. I think one of the most common experiences is one that chest voice is kind of unfamiliar, like real actual chest voice is a little bit unfamiliar. So techniques that you already have in your arsenal to kind of walk through that process with someone experiencing what that's like and kind of developing those skills. And then the other is that navigation of registrations above middle C kind of shifts. And it shifts in terms of where someone pre-T might have felt or experienced what they would call head voice might now feel more like flute, or might now feel more like, you call it whatever you want, like falsetto or whatever. And so in order for them to just like match pitch, their understanding of how they would set that up, you know, from the motor perspective, I think would be just totally different. So there's like a whole new remapping process for how registration navigation works as well. All of that said, it's a really fun process and really joyful. And I don't want you to get caught up in all of the things that could go wrong. I want you to get caught up in all the things that will go right. That first moment where like, oh shit, I can sing that note now. Like that's amazing, right? And being able to recover all of those parts of the range. Like not only can you sing lower now, but you still have your high C. Like that's amazing. So celebrating the joy of that and think of all the things that can go right and know that you already have all the tools you need for any of the challenges that might come up too. Like this stuff you already know. You already know how to navigate through testosterone voice changes, just a little bit different. Stepping off my soapbox now.
Thank you. I think we have time for one more question from the audience. Is there anyone else with a burning question?
I have a request. I'm sorry, I'm in the car. It's Edie, forgive me.
Hi.
Can I go ahead or you want me to wait?
Go for it.
I am fascinated by this concept of intractable, I think you said, Liz, larynx. And I was driving, so I couldn't get the names of the people that you said had written in the singing world about voice and T, because to be honest with you, I'm looking very deep into how women's voices change when they're put on testosterone for endocrine and perimenopause or postmenopausal issues. So I wondered if you could share those with us or tell me again or something. I just missed them.
Yep, I have a whole resource list I can send.
Oh my gosh, that would be amazing.
For sure. It includes those articles and then also a list of artists across different genres who are working professionally on the other side of tea, whatever that means for them.
I love that. Thank you so much.
Thank you so much. I have one more burning question that I think is a great way to sort of wrap us up, but I wonder if I could ask both from Liz and from Desi for an example of when it would be appropriate when working with a client to refer them, if you're the clinician, to refer them to a voice teacher, and when it would be appropriate for the voice teacher to refer them to a clinician.
Do you want to go first?
Sure. So I think for me, because I am not a singer, or I should say I'm an avocational singer. I want to work with somebody primarily on their speaking voice, kind of getting them to a place that they feel comfortable. If I really like for me, for the world and for art, I feel comfortable for the me and for the world, but for the art, I'm gonna send them directly to Liz.
Yeah, I think kind of likewise. I think the way I think about it is like rehabilitation and habilitation. So in the voice training world, I make part of my living on the belief that I think singing teachers can do speech work and are in many ways uniquely equipped to do speech work because we have trained our ears so very well. And so I love to train singing teachers to do the speech work, and all of our faculty members here do that as well. So I would refer out if there were any signs of anything that would be limiting that training from a physical perspective. So any kind of like repeated limiting tension or, disturbances or distortions in the voice, anything. I mean, like the same with any other singing client. If there was something that seemed like would be cool if I had a picture of this, that would give me a little more information. That would be the time I would refer out for sure.
Wonderful. Thank you so much. Let's give Desi and Liz and Ariel a wonderful round of applause. Thank you. This was really incredible and so extremely helpful. I know I've walked away with some tools already to put into place and a bunch more resources to look for future information to continue this journey of learning and supporting our students. And we're just very, very grateful that you spent time with us. And thank you to everybody who was in the audience today for taking an hour plus out of our beautiful Sunday afternoon in Alabama. And we're just incredibly thankful. So bravo, wonderful to everyone. One final save the date that I have is our next meeting for the Alabama chapter of the Voice Foundation, which is Sunday, October 23rd at 4 p.m. You'll be getting more information on social media and through email, but you can save the date on your calendars, October 23rd, and we look forward to seeing you then. Thanks so much, everybody.